going to do is talk about some work I've done over many, many years, but I'm actually going to bring it back to, I hope, this room we're in now. So, and also for the people who heard me speak over the last few days, I took the trouble to change every single picture. So you'll see some different ones. And I've always learned, somebody told me very early on in my academic life, put lots of pictures in, because if they're really bored, they won't look it because they'll be looking at the pictures. So hopefully you won't be bored, but there are some pictures there. It's probably not the sort of thing one should actually admit to, but bear with me. And you've all had the paper about that I've written. What this presentation will consider is some dilemmas relating to developing effective assistance with people who have lived through extreme events in a civil war and post-conflict context, as well as the South Asian tsunami within Sri Lanka. Can everyone hear me okay? I know I have a very quiet voice. It's hoped what we have learned will have wider applicability around elsewhere in the world. And that's a picture of Sri Lanka down there. It has been called the Pearl of Asia, amongst many other things. This picture I'm showing you is what I think my colleagues think I go to when I go to Sri Lanka. You know, beautiful beaches, lovely temples. And what I would say is, any of you are thinking of going on a vacation, certainly there's projects that Suma and McGill people and I am involved with, which we'd be delighted if you could give a lecture or a talk there. So it is a very beautiful country and feels a bit like my second home. The next picture, it's not too traumatizing, but it's not very pleasant. I don't wish to traumatize people, but it is to show what the Sri Lanka I see has been like. And I had to have cricket in there because it is almost a religion. You know, you're really, I was talking to some colleagues yesterday, sorry, I digress, with, I went with a, sadly passed away, a very eminent Sri Lankan psychologist, Padmal De Silva. A lot of us were doing some conference. He suddenly arrived at breakfast, unable to speak really, looking quite traumatized. We all said, what on earth has happened? What had actually happened was, in the lift coming down had been several members of the Sri Lankan cricket team. And this was so amazing for him, he could barely speak. Sorry, I do digress, but I will come back. You can see some pictures of actually the reality of much of the work I've done. And there was peace was declared in May 2009, so these things are moving forward, although for some people not as fast as one would like. I'm just going to give a few very brief statistics. There was a 26-year civil war between the LTT, the Liberation Tamil Tigers of Elam, and the Sri Lankan army. Interestingly, given that there were a lot of women, I'm sticking on these theme boys, sorry, I've got a bit of power now I'm here. They were interestingly often referred to as the boys, which was very interesting as they had a lot of female members. But anyway, that's another story, and we could get into deconstructing language, but that's not for today. Sadly, approximately 100,000 men, women and children from all the ethnic groups have lost their lives. This is a very recent study. Civil war uprooted 1.8 million people. Now the term in Sri Lanka is, the phrase is, this is the new Sri Lanka. It's very interesting about memory in societies, and some politicians telling us, no trauma, nothing has happened, we're in a new phase and we must forget the past. As psychologists and psychiatrists, we know it is not that simple. Remnants of the many battles fought. I remember once being in the war zone and being given a training about where to walk, which was always walk in vehicle tracks, because there, you know, there's no anti-personnel mines, and there were a lot used by both sides. Tsunami, just a bit of background, 30,000 people tragically lost their lives, 1 million people were made homeless, 3/4 of the coastline of Sri Lanka were devastated, 230,000 people lost family members, property or their livelihoods. Just a picture of the tsunami, and you can see how absolutely terrifying it was. I remember seeing large boats looking like matchsticks, literally snapped in two. Quite terrifying. obvious stuff. Tell me if I'm sorry if I'm preaching to the converted, but just things I think that we sometimes forget. The explanatory models of health held by those offering help or treatment and those requesting it may be different, as these are frequently culturally located. And as I mentioned in my talk yesterday, this also includes a professional culture of the psychiatrist and psychologist. We bring that into the room with us, whatever we think about. I have to put my glasses on to read my small notes to myself. It's sadly a sign of getting old when you need your glasses to read. I'm just going to share one little aside with you because I think it brings it a bit more to life. I had just seen a woman who'd been through a whole series of awful atrocities. She was actually from the Middle East. In a consultation, she'd left the room. I was sitting writing up my notes. Suddenly the door opened with such a burst. I thought at least, going back to Canada, there were at least 20 terrorists in the building or it was on fire. She actually came in and she said to me, please, I've seen someone I know in the rating room. Could you please tell them I came because I've injured my arm? I don't want them to know I've come for anything psychological. That has too much stigma on discrimination. And I think these are things we hear, but it's easy for us to forget. Power differentials and dynamics, already been talking about. The point I do want to make is about the exoticization of the other, that we need to be very careful that we don't do that. Just a little example of exoticization no, perhaps I'll come back to that. Many health professionals descended upon Sri Lanka after the tsunami who failed to consider the local context, culture and systems. In fact, they actually set up a desk at the airport for people who were coming in to offer help, which perhaps, well, says many things. I don't need to overestimate. Psychiatric, psychological infrastructure is relatively young in Sri Lanka. There are a wealth of traditional ways of dealing with emotional distress. I sometimes think it's very arrogant of us to go in and assume that we know best when there have been systems that have been used for literally hundreds of years. There's a very small psychiatric, psychological number of people working there. One of the projects I have been involved in has been setting up a clinical psychology training program in Sri Lanka, which I'm pleased to say has now been actually taken over by Sri Lankans, which was always the model and as it should be. Relevance of psychological models developed in the West to an Eastern country is a complicated one. Someone's talked about that. Ayurvedic medicine is practiced widely, as is cedar medicine. And a very interesting book, if you're interested, Mental Health in the Tamil Community, written by 2 Sri Lankan Tamil psychiatrists working there. What do I mean by health pluralism? I've mentioned health pluralism. What I mean is a multi-layered or diverse range of explanatory health beliefs and a concomitant, I can't even speak English today, wide range of coping strategies or help-seeking behaviours, as well as a varied range of designated healers, which may include indigenous healers and religious leaders. I had a picture I wanted to put in there, which is of, I stopped at a shop to buy a drink in Sri Lanka, and you could buy pictures, and these were all, you know, to help you travel well and to bring you. There was a Christian one, there was a Hindu picture, there was a Buddhist one, and there was also someone who was certainly not the leader of the militants, but was probably somebody quite influential there. And I just thought that showed the kind of pluralism and diversity of systems that people believe in. Also, it has more bank holidays in Sri Lanka than any other country in the world, because there's 4 major religions, and as it should be, they all have their holidays recognised, which means it's quite rare that you actually do a full week's work. It does mean that the GDP is not quite what it might be, but I do slightly digress. But just some pictures of different healers. Wayside Hindu Temple here. So I'm trying to keep you interested with lots of pictures, but hopefully the text is also interesting. Relationships between a culture and its healing ritual is a complex one. Kleinman is the one who's most quoted. We've heard from Jill this morning. We're going to hear from William later. Cultural, socio-political, existential, spiritual and personal meanings and expressions and responses to civil war and traumatic events and their aftermath are likely to be mediated by each individual in the context in which they occur. People have talked about the importance of diversity and working multidisciplinary. I cannot emphasize enough about context and meaning making of the individual person. It's easy to make assumptions. A friend of mine who works in marketing, I think this is a bit glib, but bear with me, said the term assume says actually don't make an ass of you and me, which is a bit of a kind of marketing, but you get my point, I hope. A temple which holds a relic of the Temple of the Tooth, which was actually bombed. Again, you can see the beauty of the country here. But health pluralism is widely found in Sri Lanka. The people identified as healers may not always be those who those roles would be ascribed in the West. Pre-indigenous healers, local rituals and traditions have an important role in assisting people to live and deal with life and traumatic events. Again, going back to the exoticization of the other. I was talking to a Japanese colleague earlier, and I wanted to say we have this strange thing, and I don't quite know why we do it in Britain, but if we spill salt, you're supposed to put some over your left shoulder for good luck. And she told me that after you've been to a funeral, when you go to the house, someone will bring salt out to cleanse spirits. So I think just to think about all the traditions and rituals that are in all cultures, some work that's been done. Working with local traditions is important, rather than individual trauma diagnosis and therapy, and that is the preferred option for many people. In a civil war situation, I know we've moved on from the civil war, if people are moving around, it can actually cause suspicion. Why are you going? Why are you going through checkpoints? And going through a checkpoint is a very unpleasant experience. I'm white, I was going to do some training. I happened to have 2 mobile phones, one for Sri Lanka and one for the UK. This was immediately identified as suspicious, and I was probably seen, given racism and so forth, as a very low risk group, and I was given quite a difficult time. So you can imagine how it might be for some others at the time. Remember the individualism of each person. Culture is not defined merely by country of origin, but it's multifaceted. And I'm going to show you, some of you have seen this. This next slide I'm very proud of. This took a long time, but bear with me. Looking at all the different levels, and I think we need to think about all those levels and all those different multiple perspectives. This is a quote, some of you have heard me give this before, from a colleague of mine, Nimisha Patel. An individual practitioner may strive admirably to understand the contribution of their client's culture to the conversation created between them, but will rarely give the same scrutiny to their role of their own culturally defined system. And I think that's something it's very important for us to constantly have in mind. Actually, this is an even better PowerPoint slide, but I'm actually going to move on from this. How am I doing on time? 12 minutes, okay. Basically the point I'm trying to make here, and this will all be available, is the need to look at multi-layered, to look at individual well-being, to look at family, to look at community well-being when we think about the psychological effects of political conflict and displacement. And also the role of resilience. I'm not going to talk more about idioms of distress and explanatory health beliefs and health-seeking behaviour because Suman has talked about that, and I know William will be. So I'm just going to talk now very briefly about some projects we've been involved with to bring it down to the ground level, what we actually did. Our programmes were conducted in 3 languages, and I'm just going to do a little commercial break here for which I make no money and nothing. But we conduct our training in 3 languages, and just if anyone is interested, I brought 3 and I don't want to carry them all the way back. It's a project I did for the British Department of Health, some guidance on working with interpreters of mental health. If anyone wants one, right, one's gone already, thank you. That's 2, 3, they've all gone. It's also available on the website. Sadly, it does not feature George Clooney. I would have been a very happy woman if it had. But it's brief. The idea is for a very busy health professional can put into their computer if they happen to be seeing someone with an interpreter, and we know how many of us will have to work with interpreters many times in our professional lives, whether wherever in the world we're based. Okay, I'm going to talk very briefly, and these have been written up, so if people want more detail. about a project we did with war widows. Sadly, my main slide on this, every time I show it, crashes. So I just want to talk a little bit about the Women's Empowerment Project, which was something we did with widows in refugee camps. An idea very much was we wanted to take the stigma away from having mental health issues and associated. So we actually embedded this in a 5-day training where we talked about things like primary care, we talked about things like employment opportunities, as well as the team of Sri Lankans I was working with. We also brought in local experts, the idea being that as well as information sharing, they would actually be sensitized to the needs of the widows, and that would bring some benefits. Another project was a play activity program we did. We ran it in refugee camps from 1982 to 2008. It was a multi-level intervention. We worked with children. What we found was that often there was so much apathy, people were so distressed and apathetic that very little was going on at all in the day. Our initial idea was to go and give some structured literary play. It grew as we developed it and thought about what we were doing, and we involved parents and carers, community leaders, health and education workers. We drew on research literature, community resources, and we also tried to work with people like directors of education and director of health. So it really was a multi-level intervention to try and sensitise people to the needs of children and families, quite a systemic approach. I had a very nice slide here where you actually saw the skipping, but I had to delete them because of the time. So it was based on the philosophy holds well-being is multifaceted and psychological health is embedded in a matrix of well-being. We had a holistic or psychosocial model which evolved. Each programme was evaluated. We also had 2 formal evaluations done. The programme aimed to provide a structured environment where carers' feelings and patterns concerns were considered, developed an intervention programme providing knowledge about the needs of children for healthy development. We also did a lot of sharing about survival strategies. It's very easy to concentrate on the difficulties, and it was amazing for women to share actually what had been their survival strategies and what had worked. Oh, I'm going to go back, I like that bouncing ball. Play activities, the role of, thank you, it was worth it for that. The role of play as a therapeutic or developmental activity is well documented in the literature, particularly in the more psychodynamic and psychoanalytic and after violent conflict or disaster. There are some criticism about evaluation is very complex. One may argue that you can do some Western psychometrics after such a programme and you may or may not see a change in the level of functioning for the children or perhaps their carers. I would argue you need to do a much more complex evaluation. Some of the things we looked at were things like because we also tried to do something around education. Schools were starting to accept children who've been living in refugee camps, which they hadn't done previously, because it had been seen for some bizarre logic as stigmatising to have those children in your school. Exactly, your expression says it all. But this was a discourse that was dominant in those areas. We drew upon the Save the Children principles, which are a long-term perspective that incorporates the psychological well-being of children. We adopted a community-based approach that encouraged self-help, built on local culture, realities and perceptions of child development, promoted normal family and everyday life as much as you can in a refugee camp when you've got very little personal space. Monica talked about ethics, and ethics of things like confidentiality when you've got no personal living space are very difficult. We focused on primary care and prevention of further harm, and we provided support as well as training for personnel who care for children. So often we would just go and sit and talk to parents and listen to them. I would say I learned far more from them than I suspect they did from me, and also to advocate children's rights. I want to now bring us closer to home. I'm going to stick with this exoticization of the other. I'm sorry if this is a different agenda to the one, but I think it's important that we do. And I want us to think about the issues to consider when building and sustaining a health system sensitive to the needs of BME communities. It's just as important we do it in Montreal, London, or wherever as it is elsewhere. Community engagement I want to talk about as a form of critical psychiatry and psychology. Again, that's something that's often done elsewhere, but less in the West. British Psychological Society has now got a section of community psychology, which includes their values, include those of inclusivity, social justice, and improvement of health and well-being, those who base their work through non-individual intervention. As psychiatrists and psychologists, we often work very much through the individual. There may be other ways of considering we work. Just a question, if we were to consider afresh how to minimise psychological distress, do we think the main solution would be individual therapy? Please speak to me, it can be lonely up here. I can see some yes and some no. Okay. I would say that these topics are not synonymous with individual therapy, that there have been perverse incentives in the UK and the NHS to focus on treatment and not prevention. That may be the same in other countries. Good, I can see some nods around the room. I'm not so familiar with the Canadian system. But professional cultures can get very embedded. What should the role of community consultation and engagement be? And we're all members of multiple communities. I've spoken as being part of a community of women. I'm also a member of all sorts of other communities. We're all members of a wide range of communities. Can be resource effective, less stigmatizing, accessible and appropriate. I've done some very interesting work recently. We got some funding from the Department of Health to do some work around depression amongst BME elders, and we various groups could apply for the money, and one of the groups I was involved in was with Chinese elders, and it was absolutely fascinating. I could talk about that, but I'm slightly digressing. I had a wonderful time. I did Tai Chi, I did painting, I did all sorts of things. We really embedded the things around psychological well-being and depression and so forth into a range of other things. Community engagement versus individual therapy. It can minimise a model of individual psychopathology, which can inadvertently stigmatise individuals. It can focus on prevention rather than treatment, and perhaps before problems have developed. It can address problems that are identified by community members and build capacity. And I think it's very interesting. We often go in, particularly in people from the north, the south, the west, the east, it depends where you're standing and how you position, to other places and assume that what we have trained is what's wanted. Often actually far more pressing concerns are about housing, are about security. I've done a lot of work with refugees and asylum seekers, and often when you're asking them about how they're feeling and what's going on, that's really not the top of the agenda. It's actually about, am I going to be deported? Have I got somewhere to live? About my children's education and so forth. It can build in support structures and provide a normalising function, as well as being cost effective, and can work with a range of cultures. Disadvantages: evaluation may be less straightforward and complicated. If we go with a positivist model, there are so many intervening variables. But I'd also argue it can be very rich, because we can pick up on things we may not do if we go with a very positivist questionnaire which makes assumptions in advance about what we may or may not find. Issues of access, issues of confidentiality are complex, and it may be more difficult to organise. This, I just want to mention, is a NICE guidelines. NICE stands for the National Institute for Health and Clinical Excellence. Interestingly, in the UK, basically, what you really want is whatever you happen to be practicing to be recommended by NICE, because it's then seen as being evidence-based and will be funded. That's it. It's much more complicated in that, but that's in simplicity. We could have a whole debate about evidence and how evidence is measured, and what are seen as the gold standards, and why, and what that misses out. that's another debate, and our friends from Jamaica are going to talk about some of this a bit later. Interestingly, whenever I talk about that there's a nice guideline on community engagement, most people haven't heard of it. I've talked about it in the UK and they've said we've never heard of this nice guideline. They can tell you the one on PTSD, they can tell you about depression, which perhaps is something in itself. I actually wrote up with a colleague who's a sociologist and anthropologist a practical guide for health professionals on community engagement with BME community groups. Provides a practical guide for health professionals on community engagement with underrepresented communities and builds on the NICE guidelines. The NICE guidelines can actually be used to strengthen your case because if it's there, it's seen as having some kind of credibility. Offers a 4-stage process model of community consultation engagements and encourages the representation of marginalised communities in the planning and provision of healthcare services. What I've tried to do is bring it back into the room in terms of not exoticising the other. And I just want to give you some statistics, and many people in this room are on this list from the UK. Mental health services in the UK have been found to be inaccessible or inappropriate by BME community members. We've got Battelle, Lego, I've just used a few studies. Usage of mental health services by BME community members is poor compared to the white community, Bugra and Gupta. And we may think because they're not culturally syntonic, or there's a whole range of issues why that may be. And I must be getting, I can see, Jaswan, I'm getting to my time, so I won't go into those. You can imagine what those are. Racism may play a role, and perceived discrimination may adversely affect psychological well-being. And both Suman and Kwame's work is referred to here. And stigma and fear around mental health may be influenced by different cultural formulations and models. Finally, organisational, institutional and cultural barriers for health professionals and service users. There's often a notion that as certain communities don't use mental health services, an assumption is made that they don't need them, and it's self-perpetuating. I've often been told that community looks after its own and doesn't use it just becomes self-perpetuating. Health professionals are increasingly busy, and what are seen as resource-intense patients may not be welcomed. We all know about pathways to care and how those may or may not be managed. Again, cultural fears and beliefs about mental health, an assumption that a Western diagnostic system is the only mechanism for understanding distress, although it's culturally located, and a lack of understanding of diversity. So I'm going to finish there, but what I tried to bring you was back to the room to think about, not to exoticize the other, and to think about actually what's going on every day in Montreal or wherever else we are. So thank you very much.